Hello and welcome back. My name is Dr. Duncan Lascelles, and I am going to talk to you today about therapies for osteoarthritis-associated pain. And this seminar builds on what we've already talked about in terms of the expanding science of osteoarthritis-associated pain. I'm going to talk today about therapies for osteoarthritis-associated pain, and in particular, the anti-nerve growth factor therapies. Just before we get going, I do want to reiterate my current disclosures, where I get my research funding from, who I do consulting for, the sponsored educational programs that I engage in, my investments and employment. And again, to reiterate, this program is supported by Zoetis, and the content of this presentation is consistent with local regulatory authority requirements. So, we talked in the previous seminar about OA, the disease, and we're all very comfortable with this. We think of osteoarthritis as a joint disease, and that gives us a degree of comfort. We can think about an individual joint. We can think about the imaging findings. We may even remember some of the pathology that goes on in the joint from our days of histology. But we also talked about in the previous seminar the fact that it's OA pain, which is important, and this drives deterioration of the whole subject. And so osteoarthritis-associated pain is not just a problem confined to individual joints, it's a problem of the whole patient. And just to reiterate, we talked about how pain causes deterioration of the musculoskeletal system, both locally within a limb and across the whole body. We talked about how if pain is not treated, it results in changes throughout the pain transmission system that further increase, heighten, amplify pain. And we also talked about the deleterious effects of pain on cognitive function and on the affective domains. And we emphasized how if pain is left untreated, these cumulative deterioration effects come together to cause an increased resistance to treatment. So essentially, the longer you leave osteoarthritis-associated pain untreated, the more difficult it is to treat. And remember that in dogs, osteoarthritis-associated pain, or osteoarthritis, is a young dog disease. It's initiated very early on in life. And just to build on this idea of global effects, the impact of osteoarthritis-associated pain on multiple dimensions, I've shown you here on this slide this schematic that really just shows how chronic pain, and we're talking about osteoarthritis-associated pain, chronic joint pain, negatively impacts multiple dimensions, gait and movement, the ability to perform the activities of daily living, that's function, somatosensory processing, that encompasses the idea of central sensitization. Chronic pain negatively impacts sleep, social relationships, cognitive ability, the affective domains. So many dimensions that are impacted negatively by chronic pain. And so it makes sense when I say that these dimensions contribute to quality of life. And if chronic pain is negatively impacting these dimensions, then chronic pain is negatively impacting quality of life. And I think it's important to remember this and remember the importance of quality of life, and remember the importance of certain dimensions here that you see on this slide as being important. So very often in veterinary medicine, we focus on diseases. We are very disease-centric, which is kind of interesting because on the human side, there is good evidence now to indicate that patients care more about quality of life, even over quantity, and they care more about the aspects that contribute to quality of life rather than the individual diseases. So put rather bluntly, human patients care less about whether or not they have cancer or cardiovascular disease than they care about their ability to be mobile, their ability to hear, their ability to interact with other people. And so I think it's worth just bearing this in mind. So what we're talking about here is osteoarthritis pain negatively impacting multiple dimensions. And if we anthropomorphize for a moment, those dimensions, many of those dimensions are really important. And that's what we need to be paying attention to, improving the quality of life through improving those dimensions that are negatively impacted, which means treating osteoarthritis pain. And so because of the cumulative effects of osteoarthritis pain on these dimensions, osteoarthritis pain should be treated early and effectively. Now, just as a little aside, that means that osteoarthritis pain needs to be identified and diagnosed. And there are a number of tools available to help with this. And just broadly, I divided them into these columns here. The first one, checklists. So checklists are screening checklists that help us in the clinic identify which patients may be suffering from osteoarthritis-associated pain. Then the second column here, the clinical metrology instruments, are questionnaires that will tell us about the severity of osteoarthritis-associated pain. They'll tell us about the impact of osteoarthritis pain on that particular patient. They're not tools that are used for diagnosis. They can help with that, but they're used really to follow the severity of osteoarthritis-associated pain over time, and therefore to monitor the effect of treatments. So we're just starting to see some staging systems come out that will allow us to combine owner evaluations and our evaluations to stage the severity of osteoarthritis. And the first one for dogs was recently communicated, the COAST. I just want to dip into one of these checklists because this is very new. You might not have seen this. This work was driven forward by Dr. Margaret Gruen and mainly performed by Masataka Enomoto. And this is a checklist to help identify cats that have osteoarthritis-associated pain. And the checklist, like all checklists, is very simple. It's a series, in this case, of 6 questions with yes/no answers. And if owners answer no to any of these questions, there is the possibility that osteoarthritis pain is present. And so it allows you to open a conversation with the owner of this pet about that. And it almost gives you an excuse to evaluate the patient for osteoarthritis-associated pain. What you'll see up in the top right-hand corner of the slide is a little table, and it shows the sensitivity and specificity, two kind of measures of the utility of this checklist, sensitivity and specificity, when this checklist is given to owners who have not been educated about the signs of osteoarthritis versus owners who have been educated. And that education was very simple. It's really a short conversation and having them look at a few cartoon depictions of the difference between normal cats and cats with osteoarthritis-associated pain. So just if you look at sensitivity there, so the ability to detect cats that may have osteoarthritis-associated pain, if owners have not thought about this previously, then the sensitivity is just under 56%. And you might say, well, that's not very good, except that that's a lot better than 0. And with a little bit of education, the sort of education that you can put on your website or put up in the waiting room, then that sensitivity jumps to almost 100%. So this, and again, so this is a screening checklist. This is not diagnosing for certain whether OA is present in cats. It's a screening checklist. And I just mentioned this because I think we've got a lot of work to do to identify cats with OA pain. And prior to that, we need to educate owners about the disease. But let's move on and talk about treatment. And treatment efficacy for osteoarthritis-associated pain is really based around these 4 pillars: an effective analgesic drug. And at the moment, across the globe, the approved products are non-steroidals, both the COX-inhibiting non-steroidals and the non-COX inhibiting non-steroidals, the PIPRANs. The second pillar is exercise. Third is weight optimization, so basically decreasing body weight to an optimal body weight. And then the fourth is dietary optimization with omega-3 fatty acids. And I'm just going to talk a little bit about these areas over the next few slides. Non-steroidals, as we talked about in the previous seminar, are predictably efficacious for osteoarthritis-associated pain. So we know they work. There's no doubt about the fact that they are efficacious for osteoarthritis-associated pain, both in dogs and in cats. The point I want to make here is that they are appropriately safe. And in fact, if you look at published clinical data, it is very unusual to see any difference in the frequency of adverse events between animals receiving a non-steroidal and animals receiving a placebo. Now, that's not to say they are totally safe or devoid of potential side effects. I think my point here is that side effects do occur, but at a very low level. So they are predictably efficacious. They're a great first-line treatment for osteoarthritis-associated pain, as is exercise. And in fact, the study there on the slide by Hendrickson et al. Is a meta-analysis indicating the analgesic efficacy of exercise is as good as the analgesic efficacy of non-steroidals. However, you can't harness that efficacy through exercise unless you are able to exercise and therefore have some pain relief. So you can start to see how these treatments go hand in hand. You provide a non-steroidal that produces pain relief to allow exercise to take place. As you build up exercise, you gain pain relief from that. And you can then actually start to decrease the dose of a non-steroidal. The other area here, now we're touching on the area of nutraceuticals. I really want to focus on the omega-3 fatty acids because this review here emphasizes the point I want to make. This review looked at the efficacy in terms of amelioration of clinical signs or the analgesic efficacy of a variety of different so-called nutraceuticals. And lumped in with nutraceuticals were the omega-3 fatty acids. And it was really only for the omega-3 fatty acids that efficacy was measurable in terms of their ability to decrease osteoarthritis-associated pain. That efficacy was not seen across the other nutraceuticals, such as glucosamine chondroitin sulfate, UC2, and all of the others. So I actually prefer to take the omega-3 fatty acids out of that supplement bucket and think about them separately. So omega-3 fatty acids, there is measurable efficacy associated with their use. Not as great as exercise, not as great as with the non-steroidals, but measurable efficacy. There is no to very little measurable efficacy for across all of the other supplements. And that's a huge topic and a topic for another day. Now, as I start to talk about treatment, the question always comes up, well, how about the so-called adjunctive analgesics? And the question is, do adjunctive analgesics provide appropriate efficacy? I want to emphasize that I do use adjunctive analgesics. I use them as adjuncts. I use them as add-ons to those four pillars. And I also am very cognizant of how much we know about the analgesic efficacy. So this is a little review here. It's a fairly complete review of the analgesic, the evidence for analgesic efficacy of the most popular adjunctive analgesics in dogs. And so this is a complete summary. For amantadine, there is a single study, and in that study, only 17 of the dogs received amantadine, and it was certainly showed positive results when amantadine was used in addition to a non-steroidal. For gabapentin, as of early this morning when I checked, there are no studies even looking at the efficacy of gabapentin for osteoarthritis-associated pain in dogs. So we just don't know. And for tramadol now, despite it being used quite extensively over the last 20 years, we now have good data to indicate that on a group basis, tramadol is no different to placebo. And those are strong data. Those are force plate data there. Now, that's not to say that tramadol, gabapentin, amantadine may not be useful for individual dogs, but on a group basis for tramadol, the data are very clear now that tramadol is no different to placebo. And moving on from the adjunctive analgesics, there are many other purported analgesics. And I think the next few years are going to see us learn more about whether or not there is analgesic efficacy associated with these. And the list I'm putting up here, and I would say there's a lot of potential for some of them, and there's very little potential for others to provide clinically meaningful analgesic efficacy. But I want to switch attention now and talk about a few newer and emerging treatment approaches for OA. And I'm going to start by talking about treating the disease of OA. And you've heard this a few times from me. There's the disease of OA, and we certainly are interested in decreasing that, in treating that. And then there is osteoarthritis-associated pain. And I think when we're talking about OA, we need to be very clear what we're talking about, particularly when it comes to management of those two different things. So here I'm talking about treating the disease, managing the disease, the organic disease of OA. And my first point is that caloric intake makes a huge difference. I'm sure some of you may be familiar with this, the so-called lifelong Labrador study, where essentially there were two groups of puppies who were genetically matched. So puppies born to parents, to sires and dams who were prone to developmental joint disease, were randomly assigned to one of two groups. They ended up with 24 puppies in each group, genetically matched. All these puppies have a predisposition to developmental joint disease. And these two groups of puppies, 24 in each group, were managed identically throughout their life, with the only difference being that while one group was allowed to eat whatever it wanted to, pretty much, I mean, these were Labradors, they had to be held back just a little bit, but one group essentially eats whatever they want to, the other group was fed 25% less than that first group. So the only difference between these two groups is caloric restriction in one group. And these dogs were followed throughout their life, and the data that you see on the slide here shows the radiographic evidence of hip osteoarthritis at different ages. And so let me just drill down on this. So if we look here at the control-fed group, at the age of 10, you can see that 19 out of those 24 dogs had radiographic evidence of hip osteoarthritis. That compares to, in the restricted fed group, 6 out of 24 dogs at the age of 10 had radiographic evidence of hip osteoarthritis. That is phenomenal. That is a dramatic. You're going from 19 out of 24 down to 6 out of 24 dogs showing radiographic evidence of hip osteoarthritis. The difference purely being to caloric restriction. So I think that speaks for itself. It's not easy, you have to convince your owners to keep their dogs slim over the lifetime, but this is where you're going to see dramatic effects on the development of osteoarthritis, the disease of osteoarthritis. Being a surgeon, I have to mention that surgery may have a role in treating the disease of osteoarthritis. And in terms of surgery, I'm talking about things like early intervention for cruciate ligament disease, possibly some elbow surgeries, and growing evidence that the juvenile pubic symphysodesis surgery can decrease the risk and severity of osteoarthritis later on in life. So surgery may certainly play a role. I think it's important to emphasize that there are no disease-modifying drugs or supplements. There are no drugs, no supplements that have been shown to modify disease progression of osteoarthritis in any meaningful way. It is an exciting area of ongoing and future research. And certainly I'm engaged in research looking at potential dual therapeutics, therapeutics that will not only retard or decrease the progression of osteoarthritis as a disease, but also at the same time provide pain relief. So an exciting area of research, but we have no disease-modifying drugs or supplements at the moment, none that show a clinically meaningful response. So now I'd like to move on to talking about treating the pain of osteoarthritis. And I'm going to start by this idea of individualized treatment. So this is something which where there's a lot of research on the human side and a growing amount of research in veterinary medicine, the idea of if we know what is driving pain in an individual, we can treat in an individualized way. And in the previous seminar, you saw this schematic here, and it basically just, in a very simple way, says pain can be driven by changes in the periphery, in the central nervous system, or changes in higher centers in terms of decreased function of the endogenous analgesic system. And I certainly emphasized in the last seminar that all of these changes are driven by peripheral joint pain, but all of these changes contribute to pain the patient perceives. And so if we could predict which changes are present in an individual animal, then we could target our analgesic treatment. And so that's something that is being worked on for the future. At the moment, it's a bit of a guessing game. We select an analgesic, give it to an individual, and monitor response. The future will be that our selection of analgesic will depend on the individual neurobiology in that patient. Another emerging area of treatment, a very exciting emerging area, is around local treatment, intra-articular treatment. And I just want to highlight one area that I think is particularly exciting. And these two studies that I put on the slide pertain to different therapeutics. One is capsaicin and the other is racintoferritoxin, different therapeutics that achieve a very similar thing. They basically exhaust, burn out some of the sensory neurons in the joint. So if you remember in the previous seminar, I emphasized the importance of those sensory neurons in the joint and that they become hyperactive, and they that contributes to pain and contributes to the disease in the joint. And so these treatments here are treatments that basically overstimulate some of the sensory nerves so that they burn out for a period of time, decreasing the hyperalgesic effects of osteoarthritis-associated pain. So that's something to watch for the future. And then finally here, we come to anti-NGF in terms of treating the pain of OA. And it's not an overstatement to say this is probably the most exciting therapeutic advance in 25 years in human and veterinary medicine in terms of controlling osteoarthritis-associated pain. And this is all built around what we talked about in the previous seminar, this expanding science of osteoarthritis-associated pain. And you'll remember this figure, and you can see there the role that nerve growth factor plays in local hypersensitivity of nerves and also in local inflammation in the joint through its effects on inflammatory cells and also through its effects on increasing the neurogenic inflammation. Just to recap very briefly, so nerve growth factor is released from the degenerating tissues in the joint, and it binds to its receptor TrkA on primary afferent fibers. Also, nerve growth factor will bind to TrkA on various inflammatory cells, including mast cells, and cause them to release pro-inflammatory mediators and more nerve growth factor. When nerve growth factor binds to the sensory fiber, and what has just come up on the screen there is an illustration of that sensory fiber, at the end of the nerve, at the local end of the nerve within the joint, what it does is it phosphorylates various other ion channels and other receptors, and so basically makes those receptors more responsive. And so that's how it sensitizes the end of nerves. But if you remember, what I talked about in the last seminar was that then that complex, nerve growth factor TrkA complex, gets translocated to the dorsal root ganglion where the cell body of that neuron is. It increases transcription and increases transcription of neurotransmitters and ion channels, receptors. And so you get more receptors expressed at the periphery, more release of pro-inflammatory mediators in the periphery, and greater release of neurotransmitters at that central terminal in the dorsal horn of the spinal cord. So nerve growth factor is causing this nerve to become sensitized and changing its phenotype, the way it looks, making it more responsive, leading it to play a greater role in producing noxious signals, which will be interpreted as painful, and increasing its role in contributing to local joint inflammation. And those diagrams and explanation are detailed in Masataka Enomoto's review that was published in the Veterinary Record. And we also detail how there's strong evidence that across the basic sciences and clinical sciences, across multiple species, nerve growth factor plays an important role in osteoarthritis-associated pain. And because of that, various strategies have been developed to reduce nerve growth factor or to prevent its action. And so free nerve growth factor can be reduced using monoclonal antibodies. You can prevent nerve growth factor from binding to the TrkA receptor, or you can decrease TrkA receptor activation. The approach which has been looked at most so far is the anti-nerve growth factor monoclonal antibody. So a classical monoclonal antibody produced that binds nerve growth factor and prevents its interaction with the TrkA receptor. And again, this is detailed in that review there for you. On the human side, anti-nerve growth factor trials have been underway for a while, and in development are two at the moment, Tanezumab and Fasinumab. I don't know why they have to have such crazy names, Fasinumab. Anyway, regardless, one from Pfizer Eli Lilly and one from Regeneron Teva. Let me just show you a bit of data here on the efficacy of Tanezumab in humans. And on this graph that's coming up, you'll see on the y-axis there's the reduction in pain from baseline. And this graph is detailing the reduction in pain with 2 doses of Tanezumab 8 weeks apart. So these are single injections 8 weeks apart. And the gray line there at the top part of the graph is the placebo group. There's always a placebo effect. And the colored lines show a dose-related reduction in pain as a result of those injections of Tanezumab. Probably the approved dose is going to be something around about what I've indicated on the chart there. Now, interestingly, so one thing, if you're used to looking at clinical data, one thing you would pick up on is that reduction in pain over placebo, it looks pretty robust. And indeed, the efficacy of Tanezumab in many of the studies has been greater than that of non-steroidals. So you're looking at a novel mechanism of action with efficacy as good as, if not greater than that of the non-steroidals. There have been adverse events. I mean, no drug, no therapeutic is devoid of adverse events. And I'm just detailing here the incidence of adverse events from one of the more recently published studies. And you can see there for serious AEs, there was no difference between placebo in red and Tanezumab. I've highlighted that in blue in terms of serious adverse events. So no difference between the groups. No difference in terms of patients who discontinued treatment due to adverse events. The one area where there was a difference between placebo and Tanezumab treated patients is in something called rapidly progressing osteoarthritis. And this is where the osteoarthritis developed more rapidly in certain patients. And that was significantly higher in patients receiving Tanezumab, albeit at a low level. Now, this is something that's been looked at and investigated in humans. Rapidly progressing osteoarthritis has not been seen in any of the preclinical animal studies and not been seen in any of the cat or dog studies. No one's quite sure why that is, but I think one thing to remember is the data here from humans with a particular biologic that is humanized. And that biologic is very different from the biologics, the anti-NGF biologics that are used in other species. But it's certainly something that we need to watch for. So adverse events aside, there are benefits. There are very clear benefits of monoclonal antibodies in general. They have a long duration of action, so a long half-life, which means you're talking about intermittent administration. They're injectable, highly specific, and do not, in general, cross the blood-brain barrier. Now, monoclonal antibodies are being manufactured to cross the blood-brain barrier, but in general, they do not. And there's a low risk of toxicity with the monoclonal antibodies. In general, safety is pretty good. Across the species, anti-NGF strategies are remarkably free of adverse effects. Distribution to tissues is low, it's slow because of their large molecular size, because of the blood-brain barrier, and because of functional equivalence to the blood-brain barrier at particular organs like the adrenal medulla, peripheral nerves, peripheral ganglia. And I think it's worth remembering that anti-nerve growth factor monoclonal antibodies do not eliminate all NGF, they just decrease it in the easier to reach tissues. And species-specific anti-NGF monoclonal antibodies are being developed. Technology now has progressed so that they can be manufactured in a cost-effective way, and in a way that preserves the high affinity and potent bioactivity of the original monoclonal antibody, and in a way that really minimizes the risk of immune reactions. These are biologics, so they have to be species-specific, or they would mount, or the individual animal would mount an immune response to them, decreasing their duration of efficacy and negating the ability to provide follow-up treatments. So caninized and felinized anti-NGF monoclonal antibodies have been produced and tested. And I'm going to talk a little bit about some of those early results. One thing that I want to emphasize is that we as a profession have made great progress in measuring pain. The outcome measures across different dimensions have been developed, tested, and validated. However, placebo effects are still problematic because for most of these studies, we are relying on owner evaluations. These are subjective and prone to placebo effects. And in dog studies, we expect a placebo effect in terms of the number or percentage that improve to be around about 40%. In cats, that's even higher. Something over 80% of placebo-treated cats improve, according to owners. And that's very difficult to overcome. And so when you see positive effects, I think it emphasizes just how meaningful they are. Let me show you a little bit of data here from the canine studies. So this is an early proof of concept study looking at a canine-specific anti-nerve growth factor monoclonal antibody in dogs with moderate to severe OA. A simple study design, a 2-week baseline period, a single treatment, and then they were assessed over the following month. And they were assessed using validated owner questionnaires of various sorts. And what you can see here are the results of the load. In the gray there on the left side of the screen, the changes in load scores in the group of dogs that received placebo, and in green on the right side of the screen, the changes in load scores in the dogs that received the anti-NGF monoclonal antibody. Significant and clinically meaningful reduction both after 2 and 4 weeks following a single injection of the anti-NGF monoclonal antibody. And now if we look at another clinical metrology instrument or another questionnaire, this is the client-specific outcome measures. And what I'm doing here is I'm comparing the scores in each group on day 14 and day 28. A lower score here means a reduction in pain and disability, an improvement in mobility. And you can see there a significant difference between the anti-NGF treated dogs and the placebo-treated dogs, both at day 14 and day 28. This next slide just helps put these treatment effects into context. And what you can do with measures is to convert them into success failure. So rather than using continuous data, you can say, okay, let's set a bar, and dogs that reach that are successes. Dogs that don't, even if they improve, are failures. And so in terms of how that would parse out for a non-steroidal like carprofen for the CBPI, In one study here, you're looking at a 46% success rate with carprofen, 23% success rate with placebo, a delta there of 23 percentage points. In the study I just showed you, also looking at the CBPI, the same outcome measure, again at 14 days, you're looking at 46% success in the anti-NGF group, 8% success in the placebo group. The important thing there to look at is the delta, the difference between the anti-NGF treated group and the placebo group. And that is 46 minus 8 is 38. And so that delta is bigger than what has been seen with carprofen in other studies. Also, if we compare apples for apples, looking at the CSOM at 28 days, you can see there in one study, 73% success rate with in the meloxicam treated dogs, 47% success rate in placebo treated dogs. And again, looking at the study I just presented, we have a 67% success rate in the anti-NGF treated dogs, 23% success rate in placebo treated dogs. A delta there is 23, 33, 43, 53, 63. I have to count on my fingers. 63, so that's 44, I believe. And the delta in the COSI study is 47, 57, 67, 26. So again, a larger delta with the anti-NGF. Again, just I think a suggestion of greater efficacy here with the anti-NGF strategies. All right, what about cats? Work has been done in cats, and remember, in these feline studies, there is a very high placebo response rate, over 80% positive responses. Now let's have a look at the proof of concept study here. This was run by Dr. Margaret Gruen. 34 cats is placebo-controlled, randomized, blinded. For outcome measures, there was objective measurement of activity and owner assessment. So both objective measures and the subjective measures. The study design, very simple, a baseline period. On day 14 there, you can see cats were randomized to either placebo or anti-NGF monoclonal antibody, and then they were assessed over the following 9 weeks. Throughout the study, they wore little activity monitors so we could measure how active they were, and every 3 weeks during the study, we captured owners' assessments of how they were doing. And I want to focus on the activity measures here because these are dramatic data. What you can see there is the purple arrow indicates the time of administration of the anti-NGF. And so that 0 is the starting point, the baseline. And then the 2 lines there in green shows you how activity altered over time compared to baseline in the placebo-treated cats, and in blue, how activity altered over time compared to baseline in the anti-NGF treated cats. A dramatic difference. To put this in perspective, that's roughly a 12.9% greater activity over placebo in the first 3 weeks. And when you look at other therapeutics, so here meloxicam given at 0.035 mg/kg daily for 3 weeks, there was a 3.32% increase in activity over placebo. So again, it's reiterating this quite dramatic therapeutic effect from the anti-NGF monoclonal antibodies. Look at the owner's assessment. This was the first time owners were able to detect a benefit of a therapeutic over placebo in a blinded parallel group design study. So it's the first time that's ever been reported that owners can actually see the difference in their cats between placebo and a putative therapeutic. And when owners were asked, did you think your cat received the active therapeutic or not? Most owners got that right if their cat had received, in terms of guessing if their cat had received the therapeutic. For owners of cats who had received the placebo was pretty much a guess, a toss of a coin there. There were no adverse events attributed to anti-NGF in this feline study, and positive effects detected by owner subjective assessments and objective accelerometry. I think the thing to emphasize here is this was a single subcutaneous injection, and I think sometimes we forget the burden on owners when we ask them to give an oral medication to their cats. And I made this mistake for years. I would diagnose osteoarthritis-associated pain in cats, and I would prescribe daily non-steroidal, maybe in addition, twice a day gabapentin and once a day amantadine, and adding omega-3 fatty acids to the diet. And I would do that without thinking about it. And it was only when I had to medicate my own cat that I realized most owners have one opportunity once a day to get one thing into their cat. Oral medication is burdensome. And I think the idea of there potentially being a therapeutic that is a single subcutaneous injection providing many weeks of pain relief is very exciting. So with that, I'm going to draw this seminar to a close. Thank you for joining me. I hope that I've given you a bit of an overview of some of the more recent and upcoming advances in the approach to managing OA as a disease and in terms of managing OA pain in cats and dogs. So once again, thanks for joining me.